Liebe Kolleginnen und Kollegen, liebe Freunde des Amboss Studientelegramms. Marcus at home is pleased and honored to welcome Dr. Anderson, who is a global leader in the fight against COVID-19 and the #1 international expert in the field of SARS-CoV-2 vaccination in children and adolescents. We are positive that in these days in which we see so many drawbacks in our national and continental European vaccination efforts, that it may be of some hope and comfort for us to look to those countries who did better in the last weeks and months and who are now able to expand their own vaccination strategy beyond high-risk individuals and healthcare workers, and who may now not only consider to start, but actually are starting to vaccinate, among others, children and adolescents. So my co-moderators today are Professor Sören Becker, who's heading the Department of Microbiology at Saarland University Hospital Center, and Anja Scheuer, also from Saarland University at Homburg, Germany. My name is Gunnar Heine from Frankfurt in Germany.
Dr. Anderson is an associate professor of pediatrics and medicine at Emory University School of Medicine and has published several high-impact papers, including a recent New England Journal publication on the SARS-CoV-2 vaccine. And I would like to start by asking you how children in general are affected by an infection with SARS-CoV-2, because mostly you hear that they're only mildly affected if they contract the virus, but then there are a few cases of a multi-system inflammatory syndrome kind of disease. So maybe you can tell us about that.
Sure. Thank you so much for having me today. And I'm thrilled to get a chance to talk with my European colleagues and look forward to the discussion today. So a few words of context. When we think back to the COVID pandemic, and as we've crossed the 1-year anniversary at this point, I think one thing has become quite clear that was not clear in the initial days and months as SARS-CoV-2 began to emerge, is that children absolutely can be infected with SARS-CoV-2 and can develop disease from COVID-19, and then as well that there is this new inflammatory syndrome, which we'll just call MIS-C for short, that really can complicate many children's recovery from COVID-19. When we think back to a year ago, the initial data coming out of China suggested that only about 2% of cases were coming in children. What we've seen here in the US is that that's actually about 12, children account for about 12% of all COVID-19 cases. So there's a dramatic underestimation of the amount of burden that exists in kids based off of the early data. And so I think, unfortunately, as a result of that, many physicians, certainly here in the US, have continued to neglect the importance of children in terms of COVID-19. And that's been unfortunate for the health of our children.
Okay. And then on the other hand, there has been talk about children being spreaders of the disease, and which has led to schools being closed down. And can you maybe tell us about the disadvantages and the advantages of that, whether it makes sense and what can be accomplished by that?
Yeah, so I think what has become clear is that particularly our older children, those 10 or 12 and above, really can transmit SARS-CoV-2 as effectively as adults can. The younger children, it's a little bit more of a complex story. They can carry as much virus as the adults do, and they certainly can transmit SARS-CoV-2 to other children or to adults, but it happens less frequently, we think, in general, than the older children or than adults. the closure of schools here in the US and in many places around the world was in part to try and decrease risk of transmission of SARS-CoV-2 among children, and then ultimately to adults, teachers, and to parents and grandparents. And there's been much debate about the degree to which that's been successful. I think that one thing that it has succeeded in doing for sure is that it's blunted RSV and influenza such that the seasons have been dramatically impacted in comparison to what we usually would see from the burden standpoint. The impact upon SARS-CoV-2 transmission is a little less clear, but is likely to have also impacted that, at least to some extent, but at a huge cost to our children's well-being in terms of their state of mind, their sense of what's actually normal, their ability to interact with their colleagues, their ability to engage in sport, whether it be football versus basketball versus wrestling or other track events and so forth, or singing in the choir. Many of these things are not options or have to be dramatically curtailed due to the COVID pandemic.
Mm-hmm. So what does the situation look like right now in the US? Are schools back open? Are they still closed? Does it depend on the location?
Yeah, so it's a point of great debate here in the US where a number of school districts do still remain closed, but there's been a real push on the part of the US government to try and get schools to reopen and to do so in a safe manner. I think what we have learned is that it can be done safely for many schools, but not necessarily all schools. But clearly the keys as far as social distancing, wearing masks, and washing of hands can really blunt or minimize risk of transmission within the school setting.
So when we discuss vaccination of children, do we rather discuss this issue with the background to protect the family members, particularly grandparents of the children, or should we advise the parents to go for vaccination with their children in order to protect the children themselves? What would be the major target, actually?
Yeah, so when we think about our society and our communities, there's been kind of a siloing, what we would say here in the US, where we think of children independently of adults frequently. And the simple reality is that in our houses and in our communities, these populations are mixing together on a regular basis. And so what happens in one population will affect the others. So I think that that clearly there would be some direct benefit to our children from vaccinating, and I think that that is really one of the primary reasons to move forward with advancing vaccines for children. But there is likely to also be some additional societal benefit by, in essence, ensuring that there's not ongoing transmission in a segment of the total population. So if our children are not receiving vaccine, they are likely to continue to sustain and maintain transmission as we continue to have new children coming into that cohort each year. We'll see continued transmission in the population of children, with then leaping into adults who are unvaccinated or unvaccinated groups of adults or immunocompromised adults. So I think among the most effective strategies would be for vaccine to be available for our entire population.
So you have written quite a number of very interesting papers and review papers, and we will give the links in our show notes. And one very important issue of which I heard for the first time actually, are some safety concerns, what you call the safety concerns of vaccination in children, particularly the idea of vaccination might induce the MISC or also the antibody-dependent enhancement. Could you just try to explain in a few words what this would refer to?
Sure. So when we think about children, they are not just small adults, but they do differ in terms of a number of different things, including their size, their fat distribution, their surface area, and a number of other factors that may well result in the dose of vaccine that's needed for an adult not necessarily correlating with the dose that's needed for a child, particularly as we get further and further away from kind of the teenage group. From that standpoint, I think a key thing to emphasize is that that we want to ensure the safety of any vaccine that would move forward in children. And the best way to do that is to do careful clinical trials where we identify the correct or best dose to administer, and then also to carefully monitor for potential side effects and issues. So one of the issues that is in many people's minds still is the issue that had happened with RSV back in the 1960s, where there was an enhancement of disease with an inactivated RSV vaccine that was initially tested in clinical trials. As such, there's been a tremendous amount of work to understand that issue that had happened in the 1960s and to learn from it. One of the things that that has come out from that is that that for many of these respiratory viruses, having a Th1 biased T cell response is probably beneficial rather than a Th2 biased response. And so when we've looked at the adult vaccine studies, we have seen a Th1 biased response that's happened across multiple of the vaccine platforms, and that provides some degree of reassurance on that front, that we would be unlikely to see vaccine-associated enhanced respiratory disease from SARS-CoV-2 vaccine. As well, from the adult clinical trials, for which we now have very extensive data across multiple different platforms, we're not seeing evidence of vaccine-associated enhanced respiratory disease. So these are very reassuring that we think it would be unlikely to see this issue occur in children, but again, it's important to adequately test the vaccines extending down into kids.
Right, thank you very much. I'd also like to join in with some questions. With regards to the vaccine development, we've been hearing news over the last couple of days that Moderna is currently running trials in children as well. So I'm not very well aware of where we stand with regard to the development, and maybe also what's the window at the horizon when vaccines will get available for children. So could you try to summarize what you know when we might be able to have access to vaccines for children, and if so?
So again, having data for kids, I think, is really crucial because we do want to be able to reassure our members of the public that these have received good testing and appropriate testing to identify the safety in children. So here in the US, there are several things that are worthwhile mentioning. So first is that the Pfizer vaccine had extended down to age 16 in their clinical trials, and they have fully enrolled that trial after they further expanded down to age 12. So they will have data from 12 through 17 available sometime in the future. At present, it's not clear exactly when in the US Pfizer will be able to go to FDA with data from those kids aged 12 through 17 to apply for an EUA. But one would anticipate that that could be forthcoming in the next months here. Moderna had also then enrolled a 12 to 17-year-old study, which they called Teen Cove, and the exact status of enrollment, I think, is not quite clear at the moment, but it's thought to be close to being full, if not completely enrolled. That would as well provide additional data in those 12 to 17-year-olds about the safety of the Moderna vaccine. So I do think it's quite possible that over the next few months, we'll have data that will be available to be submitted to FDA here in the US for potential vaccine licensure of both vaccines down to age 12, should the safety and immune responses be similar to what was seen in adults. Then the big news here in just the past couple days is that Moderna has opened their clinical trial in children 6 months through 11 years of age here in the U.S. To enrollment. And so that is excellent news that one clinical trial has begun here in children less than age 12, and we look forward to hearing additional data about timing for results from that. But one would anticipate that the data there would be slower to become available, and looks very unlikely that would really have sufficient data before next school year for those under age 12.
Right, thank you very much. And with regard to the other vaccines, be it Johnson & Johnson or other vector-based vaccines, is there any theoretical reasoning to argue for or against one of those techniques, or would you rather see it for being used in children? Or do you see any specific reason when perhaps one should try to give preference to either mRNA-based or vector-based vaccines? So are there any specific considerations that might be different from the adult population?
So it's a good question. I think that that certainly the mRNA vaccines have in general had a little bit of a head start over the vector-based vaccines. And so they've been able to generate more data and extend that data down to younger ages more quickly than the vector-based vaccines here in the US. Outside of the US, we're looking forward to hearing kind of more about additional clinical trials happening with some of the other platforms as well. From a kind of theoretical or from the standpoint of would one platform be recommended over another, it's really hard to envision at this point in time that there would be a need to use one platform over another or prefer one platform over another. But again, the clinical trials will be really important in terms of helping to begin to address some of those questions that may be relevant, but at this point we don't know.
Right, okay, thank you. Maybe one question that not only addresses the vaccine question, but also the different variants that we are now seeing with regard to COVID-19. So especially the South African one, for example, which has been called also having immune escape properties. Do you know whether there's any data with regard to clinical differences or differences in transmission or transmissibility between children and older individuals? And is there anything of concern that one can already deduct from the limited available data?
Yeah, and you said it well. There's very limited data that's available. So again, a very good question and a very kind of hot topic question. From the standpoint of available data as far as vaccine coverage of, say, the South African variant, there's only the best data really come from the Janssen clinical trial, where it was around 59% effective in South Africa, which wasn't statistically different than other parts of the world in which the trial was conducted. In the laboratory, if you look at sera that, say, we'd collected from our phase 1 Moderna study, and that others had assessed from the Pfizer studies, the immune response is the neutralizing response or pseudo-neutralizing response is a little lower in against the South African variant or South African derived variant, but it's unclear whether that will correlate with actual differences as far as protection against infection. I think what has been good news and has been kind of consistently seen is that the one-off mutations, meaning those single point mutations that perhaps confer increased transmission, such as the what's called the UK variant, or the original one that was of concern, the D614G variant, those do not really impact how well, at least in the laboratory, the vaccines protect against or bind those variants. So I think that in general is good news. From the standpoint of will these be more transmissible? There is some evidence that particularly the UK-derived strain may be more transmissible, may also be associated with worse outcomes. Again, I think how that will play out and play a role for children at this stage really remains uncertain.
Okay. And maybe the last question from my side would be now, or not so much focused on the available facts already, but rather, I know it's difficult. Anybody who's asked what's going to be in the next 12 months with regard to COVID can probably also not predict everything. But as we're seeing so different developments the world over with regard to schools and young children, from school closures, from reopening schools and then reclosing again, to other countries who are trying to vaccinate as possible, as fast as possible, and try to keep schools open. What do you think will be a realistic perspective on how things will evolve in schools, let's say after this summer? So I think probably there's a number of countries where vaccination campaigns will continue so rapidly that there might also already less pressure to decide whether schools need to be kept closed. But on the global perspective, how do you think this can be managed as of September onwards with regard to schools? And is vaccination the only thing that we should rely on, or are there different approaches that you'd recommend?
Yeah, so again, great questions. I think that in general, given the fact that we know that that Moderna and Pfizer both have studies that extend down to age 12, I think that it's quite possible, and I hate to say likely, but it's even potentially likely that we may well have one or both vaccines being potentially available here in the US and potentially as well overseas, depending on what the EMA or other groups decide for our children down to younger ages, should the data from those trials again look good. I think that would be as I had mentioned previously, since those kind of older children seem to be the bigger transmitters, certainly having a vaccine available for them would be a good first step. I think recognizing the important role that teachers and school administrators play in terms of keeping the schools open. I think that many of us would favor making them a priority group, regardless of age, for vaccine receipt, and would hope that that would be possible in many countries, even with limited vaccine supply, such that we could try and keep our schools open. I think that even if a vaccine is available for our children down as low as age 12, we're probably, at least here in the US, looking at a school year in which children do remain masked and efforts are made to keep them socially distanced and so forth, because there will be issues of uptake and how quickly a vaccine could roll out to kids. There are very practical strategies that also can be effective, such as improving ventilation, opening windows may well have a real impact. And so in many countries with more limited resources and perhaps without access to vaccine, some of those strategies can be implemented to potentially decrease risk of transmission as well.
So I would maybe have two final questions on the phase 3 trials. So first would be, do you go for the same dosages as in adults, at least for the older children, or do you change dosages? And the second question would be, now that the numbers of new cases are going down, at least in the States, while they keep being elevated here in Germany, can you still focus the phase 3 studies in children both upon efficacy and safety, or can you only go for safety studies right now?
Yeah, great question. So from that standpoint, the extension of Pfizer down to age 12 here in the US, and also Moderna, had been with the adult dosing of a vaccine. So as such, it's likely that should those studies be successful, then it would be likely that it would be the adult dose that would be used. Although I think we know very little about the actual data from those studies at this point in time. So that remains an open question mark at this point in time, but that's likely. So at least here in the US and probably also in the European Union, it's likely that that regulators will not require an efficacy endpoint be established, but instead will use immunogenicity as a surrogate endpoint. So safety will need to be there regardless. But then the question is, do you see similar immune responses in children to what you might see in young adults that were enrolled in the phase 3 clinical trial? And if similar immune responses are observed and the safety is present, then I think it's likely that the FDA and the EMA will consider licensure in that setting. And they won't require an actual efficacy endpoint, because as you mentioned, the number of cases are going down dramatically here in the US, and hopefully will be going down as well in many other locations around the world. And so getting an actual efficacy endpoint is not feasible, or not likely to be feasible.
So thanks a lot. I think this has been a really fascinating talk, and on behalf of all our colleagues here in Germany, Switzerland, Austria, particularly great thanks for all the work you did in the last months and years in this field. And when preparing our talk, we were fascinated that even you are pediatric, you even published the New England paper on elderly patients or populations. So you really look beyond your nose and cover the field to a great degree. So thanks a lot. And we are looking forward to reading more from you, hearing more from you in the next months to come. Thanks a lot.
Thank you so much for having me. And again, would just encourage your listeners to receive a vaccine when one is available to you. Again, from the standpoint of the way that these trials were conducted, I think it's just critical to remember that there's not been this degree of transparency for any vaccine study performed previously, at least here in the US, where clinical trial protocols are available on the web. All the data that was submitted to the FDA, for example, was available for public review. There's public opportunity to attend the FDA meetings tremendous degree of transparency that's existed, which really provides a great deal of reassurance about the safety of these vaccines. And there's obviously ongoing safety surveillance that continues, and look forward to hearing more additional longer-term safety data. But definitely try and get your vaccine when you have one available to you. And thanks for listening, and thanks for having me.
All pleasure. Thank you.
Yes, you're welcome.